I'm going to talk a bit about sort of the overview of myeloma, and I also have some questions. Your myeloma disease activity is primarily measured by what blood test? Is it the standard M protein using the SPEP test? Is it another blood test, the serum free light chain, where they measure the kappa lambda? Is it collecting 24-hour urines in order to find out how your myeloma is doing? Or is it a bone marrow biopsy? Or I don't know. Excellent. And what is excellent is that that people know how it's really important to know when you have cancer, how do you measure it? How do you know if your cancer is getting better or not? So it is great to see that people know how their disease is followed, and then will help the folks who may not be sure of how their disease is followed. Myeloma is the second most common blood cancer. There are 100,000 people living in the United States with a remission with myeloma, which has doubled in the past 10 years. And the median age for myeloma are people that I like to say are the true adults. 30, I used to think 30-year-old was an adult, and 21, those are kids. These are true adults. And so what are the symptoms of myeloma? And you'll see a common theme of fatigue. That 60% of patients will have low red blood counts, of course, because those plasma cells are growing in the bone marrow, and there's not a lot of room there for the cancer cells and the red blood cells. So people have weakness, fatigue, and sometimes infection because of the low white blood count. They can have decreased kidney function, where the protein and especially the light chains being produced by the myeloma cells can get stuck in the kidney. They clog up the filter and cause kidney damage, and that causes weakness. They can have bone damage because the myeloma cells that stay in the bone marrow look for other places to live, so they go to other bones, thin out those bones, and you can see thinned out areas of bones in 85%, probably more percent of patients, and some of those will lead to fractures and bone pain. And then there's increased bone turnover by the myeloma cells, again, because they like to live inside the bone, causing high calcium levels, which causes confusion, appetite loss, and weight loss. And so, but one thing is that about 10 to 20% of patients with multiple myeloma will have no symptoms at all. And that's kind of the new area that we're looking at treating the folks to try and prevent all these symptoms of multiple myeloma. And this is one of the key slides. This is one of my favorite slides of the whole presentation, is the things that optimal disease management, the things that you should interact with your doctor about on a regular basis, is knowing the laboratory and imaging testing and making sure of your diagnosis. Every new patient I see, I give them a printout of their diagnosis, and they carry that from second opinion to place, show their family physician, this is the disease that I have. And so I give everybody their laboratory test, but especially their diagnosis. Staging and prognosis. It's very important to know staging. Staging tells us how aggressive, how difficult will it be to treat your disease. And the studies that show that patients who know their stage interact better and are better decision makers for themselves with their provider. So it's very important to know your stage in 2017. Obtain a second opinion. I take second opinions. Patients come to me for second opinions. I send patients out for second opinions. To get more, this is cancer. It's not, anything about your carburetor. You need to get opinions of lots of people because this is your life. And so it's very important to get a second opinion. Know the standard of care. If your doctor says that I want to use a shampoo to treat your myeloma, you should say, no, that's not the standard of care. We're going to do something else and not a shampoo. I don't know why I'm talking about shampoos. I don't know. They may have invented a shampoo for myeloma. They would have told me. And then consider clinical trials. We know that most patients do not pick their myeloma doctor based on the availability of clinical trials. You should be choosing your physician that you used to treat your myeloma and with their availability of having clinical trials, because someday that may be a very good thing to have in the back pocket. Very important slide. So there are three sort of basic of plasma cell disorders. There are three divisions. One is MGUS. MGUS is very common. Sometimes people call it MUGUS, and some people call it MGUS, monoclonal gammopathy of uncertain significance. It is it's very common. It doesn't turn very much into myeloma. Not a lot of plasma cells, low protein, no symptoms. A lot of people have that. Smoldering myeloma is the next step. So if you develop more plasma cells, the protein goes up from less than 3 to 3. The plasma cells go from less than 10% to 10 to 60%, but no defining symptoms, none of that CRAB criteria. That's smoldering myeloma, and that has a higher risk of progression to myeloma. So a lot of people are MGUS, a few people are smoldering, and then there are those patients that have multiple myeloma. They have some type of biopsy that says they have plasma cells that are malignant, and they have one of the CRAB features, high calcium, kidney damage, anemia, or lytic lesions, or bone damage. And it's important, the last 4 patients I saw in consultation, their doctor had told them that they had myeloma, but they did not meet this criteria. And so again, it's important to have your diagnosis and assure that you understand how they got there, so you can communicate with your doctor and communicate with the people you get second opinions with. So lab tests. So it's really important to know this is a disease that's followed by labs. Again, lung cancer, you do scans, and myeloma, you do labs. And so you need to know your labs. There's the basic CBC, which measures the blood cells, white blood cells, platelets, a comprehensive panel measuring the liver and electrolytes. The beta-2 microglobulin, we'll talk about in a little bit, but is an important test. An independent measure of how many plasma cells there are is the beta-2 microglobulin. And then in yellow, I put the sort of the critical test, the SPEP, which measures the protein level, the immunofixation, which measures the type of protein it is, the light chain test, the urine protein electrophoresis, and then the 24-hour urine analysis. And so the ones in yellow are the main tests that we use to follow the disease along. Most patients will produce an IgG, an intact immunoglobulin, IgG, IgA, IgM. About 15 to 20% of patients will only produce light chain, so will be dependent on either the 24-hour urine or the serum light chain assay. And then some patients won't produce anything at all, won't produce neither light chains nor M protein. And especially as patients live longer with myeloma, sometimes they become agliosecretory, which means they don't produce much protein, or asecretory means that they produce no protein. The other way that we check myeloma and assess it is with x-rays. We still use conventional x-rays. X-rays are a 117-year-old technology, very old technology, but it can still show you lesions from myeloma. MRI, CT scan, and PET scan are much newer, of course, and they have a much higher sensitivity, about 85% more sensitive than the skeletal x-rays. And of course, skeletal x-rays are very old. I mean, it's 117 years old. What do you expect it to do? And the PET scans and MRIs. And I think we're leaning more towards using more PET scans and MRIs at the time of diagnosis and following patients. Then the final thing is that what's actually going on in the bone marrow? What mutations cause this myeloma to act in the first place? Why is it behaving in such a way? And there are lots of ways that we can determine that. Anyone heard of the bone marrow biopsy? Heard of this thing? So, boo. But what it does do is that gives us some information. So we get those plasma cells and we look at the chromosomes, because that's where all the genetic material is. And we can look at the chromosomes and find out what mutations occurred in the cancer cells, not in your body, but just in those cancer cells. What were the mutations that caused this cancer in the first place? And it gives us an idea of the behavior. So what is FISH, in situ hybridization? Well, FISH what it does is that it is a little tag that is on different chromosomes. So here, a normal plasma cell, there are two green flags which flag two green chromosomes, and those two green chromosomes are chromosome 14. And here are two red flags that have, and these are chromosomes, one from mom, one from dad. And so you can see that this has two sets of chromosomes, one from mom, one from dad. This is a normal plasma cell. However, if you look at this myeloma cell, you see that the red dot and the green dot are stuck to each other, that this is a translocation, that those two chromosomes are stuck to each other and the information is interweaved and mutated. So now that cancer cell is reading the wrong, that cell is reading the wrong information by the two chromosomes being stuck together. Here's chromosome 4 in red, here's chromosome 14 in green, and there's 414. Those two chromosomes are stuck together. But knowing that, we know that we need to treat these patients a bit differently by knowing this information, that this is a mutation that caused this patient's multiple myeloma. A lot of patients will have triplet chromosomes. So they'll not only have one from mom, one from dad, but an extra one got thrown in when the cells divided, which caused the mutation that caused the cancer. So here's 3 chromosomes of 7, and you can see the red chromosomes are all triplicate too, and that also can cause mutations that cause myeloma, but usually those are associated with easier to treat myeloma. So it's really important to know what type, because it tells us what the risk of the disease is. It's important to know what the genomics or the mutations that occurred in your myeloma. And we're getting better at it. We went from just looking at chromosomes to looking at fish, and now we're doing genomic testing, which is getting to the heart of the actual mutations, just not the chromosomes that they lie on. And Mary had talked about the COMPASS trial, which is key in breaking down and finding out the different types of myeloma. Lymphoma has 32 different types of lymphoma. Some types of lymphoma are curable, some types of lymphoma are very difficult to treat. But there are 36 different types of lymphoma. In myeloma, we just say myeloma. We need to break down myeloma into its constituent parts, know how to treat those constituent diseases so we can offer the best therapy for the best patient. And the COMPASS trial is bringing us to that goal very, very quickly. I am super excited about the COMPASS trial. So know your myeloma. This slide is becoming more and more important as the years go on, because how we define the disease is more and more based on genomics. So when we put all this together, we put the blood and imaging tests, the genomics, the bone marrow biopsy, that's how we get the staging and prognosis and ultimately come up with the treatment. There have been different staging systems over the years. The newest staging system is awesome because it includes not only the beta-2 microglobulin, which is an independent measure of how many plasma cells there are, but also includes the cytogenetics. And so the mutations that are high risk, the mutations that are more difficult for us to treat, but also serves as the targets for future therapy. So the staging system, the new staging system is very, very good. And of course, there's stages 1 through 3, and based in part by the LDH, the beta-2 microglobulin, and the cytogenetics is a big part of it. So again, know your cytogenetics, know your staging system. With high-risk myeloma or high-risk cytogenetics, that's, as Mary had mentioned, deletion 17 and the translocations of the 14th chromosome to other chromosome partners, 14, 16, 14, 20. Intermediate risk of 414, and actually 414 has got an interesting story in that it was a higher risk disease until we knew how to treat it. We knew how to use proteasome inhibitors are very important for 414 patients, and which has helped move that from high to intermediate risk. And then we talked about the multiple chromosomes, where the triplet chromosomes, those are the standard risk patients. And so again, how difficult it is to treat is based on the risk. And what we're doing is coming in with new treatments for these different types of myeloma, and we're dividing in the COMPASS studies, helping us divide it up more. So here's my other favorite slide, is what do you talk to your doctor about? You need to know what type of myeloma you have, what's the stage of myeloma, important to know, because it helps you communicate with your doctor better. What cytogenetic abnormalities do I have? You need to know your risk and what will be coming in the future. What is my long-term prognosis? Can I bank my tissue for further analysis? Because again, the molecular part of myeloma is becoming more and more important in the very near future. And what treatment options should I consider? And know your response to therapy. You need to, and a lot of you know that if your protein goes down, that the myeloma's gone down, because you need to know if the treatment's working or not. And briefly, doing a treatment overview, MGUS we don't treat. Smoldering myeloma has become a very exciting area of clinical trials. Right now, the standard of care is observation, but very exciting. And active myeloma, we'll be talking about the treatment of active myeloma in just a second. You know, when I had hair and a high top fade, and I had a fly high top fade, we were giving crummy drugs for myeloma. I don't know if that conventional is even the right word anymore. Now the novel therapies. I lost my hair, but in the process we have Velcade, thalidomide, Revlimid, Kyprolis, Pomalyst, Feradac in 2015. And now the hot area, the antibodies and the immune therapies, which have changed the entire world with myeloma. And now, gosh, gee whiz, there's so many things coming down the pipeline. And this is an inadequate representation of the new things coming down the pipeline. So this is my favorite slide. So I've said about half of them. Myeloma biology has now increased response rates really to 100%. And myeloma survival has increased dramatically. I had mentioned before in 2004, there were 54,000 people living with myeloma. In 2011, that jumped up to 74,000. How did it go from 54,000 to 74,000? How did that happen? It's not because the incidence increased, because the incidence has been the same. Do you know why so many people? It's not because the Canadians from myeloma patients in Canada came down to the United States because we have better football teams. That's not why we did it. The reason, I shouldn't have said that. The reason we do. The reason that there's so many more myeloma patients because people stop dying so quickly, because the therapies are so much better. There's so many more people surviving with this disease. And this 2017 is going to be higher than that. It's very exciting. So it's true, myeloma is not curable, it's survivable, but boy, we're really zeroing in on the curative part of this. Very exciting. So my last question, and I'm like 2 minutes over, which of the following is true about multiple myeloma? That's a general question. Myeloma arises from a more benign process called MGUS. That's very common. Myeloma patients who know their stage felt more knowledgeable about their treatment options and were able to converse with their doctor about the options and different types of treatment. Genetic information of the plasma cells helps to stratify patients' risk between high risk, intermediate, and low risk, so that we can target the risk that people have and target the mutations that they have. I'm giving out some answers. Patients diagnosed with myeloma without even a single symptom or all of the above. Oh, excellent. So multiple myeloma patients have numerous effects on the body. The genomics are changing everything, and survival is improving because people are involved in clinical trials and the knowledge is getting incredible. So it is critical for you to be informed and empowered, because there are more options out there than ever in treating this disease. Thank you.
So we have time for 2 questions. So I thought I would thank you for excellent talk. And you've covered actually many of these questions in your talk, but let me focus on 2. One of them really, because you touched on genomics, and obviously Michigan's been a huge center for genomics. The question is, first part is easier. How do I request genomic testing? The second part is, can you really discuss a little bit targeted therapy and how you use that to help you make decisions?
Yes. So what we're finding out is that when you look at both newly diagnosed, so they're mutations. So plasma cells are actually very hypermutatable cells at their very nature in order to make all the different antibodies that we need to fight infection in the world. Those mutations, though, when you look at myeloma, there's actually a limited number of tricks that the myeloma can, that the plasma cells can mutate in order to develop myeloma. And so, the more people that we have studied in both newly diagnosed and in relapsed myeloma, the more that we see that there are very distinct patterns that come up in myeloma based on genomics. So if you look at a disease like chronic myelogenous leukemia, very rare disease, it's a type of leukemia. Chronic myelogenous leukemia is diagnosed by having a specific genomic abnormality where the 9th chromosome and the 22nd chromosome are stuck together to form a mutation protein called BCR-ABL, or mutation gene BCR-ABL. They then made a drug for that, then was the single treatment for it. So myeloma is more complicated than that. It has more genes involved and more mutations. But what we could do is using the fish cytogenetics is a very broad, very non-specific way to find the mutations. Now we have gene sequencing platforms that look at 2,000 different genes known in cancer for each individual, and then you can see that each individual has can have different mutation patterns. And when you put all those individuals together, you'll see that there are different types of myeloma. And again, just like we mentioned for lymphoma, lymphoma there are types of lymphoma that you don't treat. There are different types of lymphoma that you treat aggressively, and there are types of lymphoma that you treat a little bit. For myeloma, we use one treatment, and we need to stop that. We need to individualize treatments, and the tools to do that is to look at genomics. Lymphoma is easy because you can look at the cells. That's a large cell. Do you need to treat that with chemo? That's a small cell. You need to treat that with nothing. We don't have that opportunity in myeloma because all the cells look alike. We look at the chromosomes, they kind of look alike. When you look at the individual mutations, people are segregated into specific types of disease, and that's what we need to treat, the specific types of disease. And the way that that's done right now is with bone marrow biopsy and harvesting the plasma cells, and we hope to get better at that. Another thing that you can do with that information is you can find if there's a specific mutation that is causing the myeloma to behave aggressively, such as missing the 17th chromosome, which is missing a gene called P53, you can actually give a drug to fix that problem. If you're missing a P53, there's a drug that will make you make more P53, so it's not missing anymore. That won't work for a myeloma patient that has 3 copies of P53, but for someone who's missing it, and that's what's making their cancer aggressive, there are drugs that target that. And when you see these commercials during football games of all these crazy new drugs, it drives me a little crazy because it's for all these different types of cancer, but those can also be used in myeloma, and that's the goal, is to match the patient's mutation in their myeloma with the right drug to get the right outcome and not just pick RVD off the shelf.